thank you very much for inviting me. I was, when I was last here 3 years ago, actually, I gave my original talk on physician burnout at a time when no one was really talking about this topic, and people were kind of like, oh yeah, that's really interesting. That's true. That's like, wow, it's a great concept. Now I think everyone really knows about it, and so I have sort of evolved to really to giving a different talk on sort of how do we move away from, now that we recognize the problem, to solving it and making our lives more meaningful and fulfilling. And so that's what this talk is about today. These are my disclosures, not relevant. And so I'm going to just mention physician impairment, touch briefly on physician burnout, a couple updated literature pieces since the last time I was here. And then I want to talk about physician wellness and real life issues and solutions with with an interesting interview that I recently did. So we are stressed because of our environment. We're asked to do more. We are forced to do it on computers. We have lost autonomy and control to our organizations and our government, and sometimes we feel like we're not respected as the professionals that we are. But as individuals, we also stress ourselves because we're perfectionists and we've always achieved throughout our lives, and we've focused on this delayed gratification, which we now at some point want to at least be happy about, and we don't know if we're happy yet. And then we're really good at compartmentalizing problems. My wife always compliments me that like when she's mad about something, I can kind of put that aside and move on. It's great, but it actually does raise stress. You internalize these things, it's not the best thing for you. So it's interesting that actually this is not a new concept. You know, Karasek, this is more than 40 years ago. This was a slide that he presented in a course showing that when you look at, is there a pointer here? I'll use this. All right, so when you look at people's work, you know, we have a high job demand as spine surgeons. And what happens is if you're in a situation where you don't have a lot of decision latitude, where the decisions are made for you by your organization or the government, you end up in a high-strain job. Whereas the goal should be really to have more job decision latitude so that you can develop new behavioral patterns and evolve into a better physician. So this is nothing new. I mean, but there's all kinds of things that are stressing us out. I mean, I'm the chief compliance officer for our practice. That's our 75-page HIPAA privacy manual that we have. And then there's a 100-plus page code of conduct. And then, of course, we're every few months getting emails that we have to complete a HealthStream or Paycom course, or we're going to have our privileges revoked. So, and then disclosures every time you go to a meeting, and they're always slightly different. You always got to fill them out and remember what you said last time so you don't lie and say the wrong thing the next time. So these things are a challenge. So we're stressed, and three things can happen. We can become impaired, as some have, especially in the past. We can burn out, which is more common nowadays, or we can adapt to the current environment. Well, we know what impaired physicians look like, I think. I mean, this is one example, impairment by drugs, alcohol. There's also psychiatric impairment, and in fact, spine surgeons do have a higher incidence of depression, substance abuse, and even suicide, at least as far as orthopedic surgeons and physicians are concerned. I don't know for spine surgeons that data. But here's one other form of impairment. You know, some people are so dedicated, especially in the greatest generation that's now moving on, that you literally had to take them out of the hospital on a stretcher. And this happened to our legendary chairman, basically. I mean, he was working right up until the very end. So it is, and there's nothing, he loved what he did. He really did. So that was the problem. You didn't have enough else maybe to go to when he wasn't doing this anymore. So physician burnout, really the three cardinal elements are being emotionally exhausted, depersonalization, getting separated from your patients and what you're doing, and a low sense of accomplishment. And this is the picture I showed this last time of the left-hand side of the slide showing kind of the interpersonal issues, and it talks about substance abuse and depression and suicide. But more importantly, on the right-hand side, and the reason that physician burnout has gained traction in society, because there is a real element that affects the healthcare organizations. Because as a physician gets burned out, they do lower quality care, they have more medical errors, patients don't like them as much, they become less productive, and ultimately they have to leave or they do something else and they have to be replaced. And the cost of replacement is very high for a physician, despite the low salary you can hire a new guy at or a new woman at. So anyway, Ariely really distilled it down to three fundamental causes of burnout. Asymmetric rewards. I mean, it's really bad when bad things happen as a spine surgeon. So when good things happen, we're happy and patients thank you and they walk on. But when bad things happen, they really stay with you. We've lost autonomy, just generally as physicians in healthcare system. And then cognitive scarcity, which is the one thing that I think is worth taking away from this as far as what is burnout. I think cognitive scarcity really deals with the fact that when we are doing with so much intensity in terms of what we do, and people are amazed when you talk to a regular person about, here's what I did today, and they're like, oh my God, like that is like really stressful. And we have limited mental bandwidth, and so you can put it on your attention, cognition or thinking, and then self-control, doing the right thing, saying the right things to people. But at some point, your mental bandwidth gets depleted and you begin tunneling in. And that means you can't really work and solve problems. You become more of a tactician and less of a strategist. And you just become impulsive, and you just want to get things done. And you don't want to do the big important things because they're too complicated and you just can't deal with them right now. And that's the problem. And one sign of that is when you start having trouble retaining information, when you read an article and you can't even remember what you read 30 minutes later when you're telling someone about it. So, but we do love what we do. And so this is really the way that my chairman felt about work. And there's nothing wrong with loving what you do, and it is what probably keeps us going. So there was a study looking at activation, which is sort of being motivated by what you do, and decompression is the other aspect of work, that you have to be able to withdraw from work and recharge. And this is a study by a group at Harvard, it's published a year or two ago. And they found that when they looked at a large number of healthcare workers, including physicians and mostly others, in general, everyone felt very activated. Everyone was very much empowered by what they did, felt very good about it. But for physicians, they really had a tough time with the decompression side. They couldn't get away, they couldn't disconnect from their work, and that is probably an important focus on a way that we can prevent burnout. Another critical issue, I think, is sleep deprivation. And, we talked about this the last time I was here, but, it's hard to get. For me, it's very hard. I'm lucky. You see, they looked at residents and attendings and how many hours they slept. You see how many they worked, 68 hours a week for residents and 50 for the attendings. But 6.5 hours a night was the average. If I get that, I'm lucky, other than Friday night. And most people were getting less than 7 hours a night, which they considered to be a poor sleep quantity. But more importantly, for all of these people, there was poor sleep quality, that relative to age-appropriate controls, there was less REM sleep and more light sleep. So they're not being as refreshed by the sleep they get. So what is the way forward? Now, I don't know if any of you actually read this article. I don't know how many people actually get the New England Journal of Medicine, but this is a very important article. And Mike Weinstein's a good friend of mine. Mike Weinstein was a general surgeon. He was by far our best access surgeon at Jefferson. And he really experienced burnout in a very deep way. He also had this background of depression as in high school and in college. He really mastered it. He occasionally self-medicated himself. But he was basically in a psychiatric hospital in a straitjacket for treatment of this. And he came out of that and came back to Jefferson, to our hospital, and he was sort of like, it was a little bit like Moses coming down off Mount Sinai he had gray beard and had this very different tone. And I recently had an opportunity to interview him. I'm going to play just a portion that I've recorded of that interview. Mike, I want to first thank you on behalf of us in orthopedics, but also really generally all of us in medicine. Thank you for your candor and your open communication on this very important topic of physician stress and burnout. Look like a priest with a little white coming out of his sweater. You and I used to run together. And I'm in mornings, 5 a.m., 5-mile loop in our neighborhood with a number of other people, which was a nice socialization and situation to look forward to in the mornings when you had to get up real early. I'm curious, at some point you stopped. And I always wondered whether that was maybe a little bit of a turning point, or perhaps you could comment on what role running played or exercise like that played in your kind of trying to manage these issues.
Yeah. To be honest, I can't remember when I stopped and why. Running was great. To get up in the morning, go for a run, talk to some folks, and you feel wonderful, right? It's people talk about the runner's high, the natural high, and so that was. I remember that as a great time in my life. I really got in shape, was doing some triathlons and biking. I would run and then I would bike to work and bike home and exercise. We know is great for our minds and our bodies.
Yes. So, one of my favorite things that I like to say
I will
is,
be saying this to you
mantra
today.
of mine, is that self-care is not selfish.
Right.
And I wonder, though, whether that's realistic for people who are working 60 to 80 hours a week, who have young children at home, to come home and say, as I would say to my wife and my family, well, self-care is not selfish. I really need to get that run in the morning, which then means I have to go to bed earlier the night before so I can get enough sleep. Is there a role? How do you balance those things if you really want to be busy and stay on top of your social wellness, or your mental wellness, perhaps?
So, one, thank you for that self-care is not selfish, because it took me a long time to understand that. I felt as though I could always give and help people, but I never thought of that for myself, and I think a lot of physicians, we're great at giving and caring for others, and it's like there's this notion that the more I do and the harder I work, the more successful I will be, and the better I will be judged. And I found more recently that the better you take care of yourself, the more you're able to be present with patients and families, and truly give of yourself. This time thing is really hard. I mean, the 60 to 80 hours or plus, it's really hard to fit it in. And running certainly at that time served a great role.
I think that we've made a lot of progress. I mean, in the 3 or 4 years that I've been talking on this, and since your article was published in New England Journal of Medicine, what should we be doing now as an organization to try to improve that?
The scope of medicine has changed dramatically over the last 100 years, and we as physicians still think of things as, this is the physician's role, I have to do this. We as physicians are extraordinarily well educated. At the same time, many advanced practice providers can do a lot of the things that we do, in fact, do. And figuring out how to be more thoughtful about what types of things, like you're doing, right? What types of patients can a nurse practitioner see in an orthopedic clinic that unloads a little bit of the volume for me, not just for you, but then you get to spend a little bit more time with the patients you're seeing. She will meet them in a different way that is often complementary, right? I suspect that physicians don't necessarily truly need incentives if they're given the freedom to do what they want to do, because we are trained, we want to take excellent care of patients. And I don't think we need to be necessarily motivated to do more, because when we are motivated to do more, then it's more about doing more and earning more money, rather than making sure I'm really doing a wonderful job in the context in which I work. So I think it's very complicated, and even the idea, like you're doing some comparison and competing with others. That also, right, I think that gets us in trouble, right? I felt if I didn't keep up a certain pace, if I asked to do a little bit less, that's perceived as weak. This is a very challenging problem. We have a big problem to fix in the next 20 years, along with our healthcare system at large. I think they go hand in hand, and the more that, I think especially we as physicians, who are very highly educated, unique backgrounds, the more we wake up and notice where we're falling short and where we're actually causing harm to our caregivers and our healers, and notice where the system doesn't meet patients' needs, I think those two go hand in hand. So if we take better care of clinicians, give them more freedom and flexibility, and improve well-being, that will naturally lead towards more mission and value-based care, and better care for our communities with more dedication to those original values, why people go into medicine to begin with. So,
Yes.
and I think it's about restoring that meaning and bringing the care back to healthcare.
So you'll notice that these are the 9 guides that the Mayo Clinic has put out about how we should manage burnout. And I would tell you, I'm not going to take the time to read through all of them, but all but the last one I think he mentioned as one aspect of that discussion. So I'm going to dig in with the last few slides here and mention each of these. So the first thing is, what does satisfy us as physicians? Well, this survey showed it wasn't how much physicians were paid, it wasn't whether they were able to reduce their debt burden or how many hours they worked a week. It was their physical and emotional health that had the strongest correlation with their satisfaction as physicians. So again, I had this slide last time because I was already saying this. I'm going to say it again, that self-care is not selfish, and that regular exercise, healthy eating habits, and getting adequate sleep and rest are critical. And I do believe that if you practice the behavior, you can teach it to your patients, and that if you have better health behaviors, your patients will pick that up, they will have better health outcomes, and actually it's been shown in one study, it will actually reduce their low back pain. So the other piece I want to talk about, or another piece, is coaching. So we talk about coaching our executives, our CEOs, and all the people in the C-suite, but it's also true for physicians. And there are a lot of ways to do it. So I have this role as the Vice Chair of Academic Affairs and Faculty Development, but especially with my team as the Chief of Spine, these are the kinds of things we talk about. First of all, social and self-awareness and emotional intelligence. Remarkable that people come through medical school and really just don't have that sometimes, but we can help them with that. And it's really important to meet patients where they need to be met. And then there's the self-defeating behaviors, being a perfectionist, compulsively thorough. Those are issues you're taught to get through college and medical school, unfortunately. And then tardiness, which is sort of an outlier. Some people have the issue, some don't. Skill development. My favorite one is teaching people to say no to things because we're taught to say yes to everything. Otherwise, you're nobody. And then trying to align the individual person who you're talking to the things that are your own goals, the goals of the organization, to make it clear that we really are all on the same page. So coaching's important. Here's just a graph. Remember, we all coach our patients. So, we do patient coaching, and we have other physicians that coach us, and we have our CEOs coached, and they coach us a little bit about business things. So this really goes all over the healthcare ecosystem, as this picture shows. Other things that we can do. So optimizing clinical efficiency, I think, is really important. So streamlining workflows. I never thought I would want to have Epic in our practice at the Rothman Orthopedics organization. And I have to say I'm starting to step back on that because we are in so many different medical records or electronic systems to bill and to chart the patients and appointments, and then the actual records are in a different one, whereas Epic can wind that all into one. I'm not sure that isn't such a bad idea. It's very expensive. But I'm actually beginning to advocate that maybe we should do that because having more functionality and fewer steps will make life better. So as much as I hate the monopoly of Epic, maybe it's not such a bad thing. And then you heard Mike talk about, and I've done work to shift tasks in our practice from physicians to PAs and nurse practitioners. We've started experimenting a little with medical scribes. You guys probably, many of you have more experience than we do. We really haven't done it yet. And then other types of human assistance technology. What do you do about physician compensation? So, we're an eat what you kill organization 100%. But how do you balance being fair to people and fair to the organization? People need their time, need to be respected for what they do. And the organization needs to, no money, no margin, no mission. You got to make money to support the organization. Well, it turns out there are some studies showing that incentive-based pay does have a negative effect and increase burnout. So here's the data for oncologists, 1,000 oncologists. When they were paid straight salary, 41% complained of burnout. It was 54% complained of burnout among those who had a pure productivity-based pay. And for surgeons, you can see the same sort of data on a larger number. And look, like I said, we're incentive-based. I wouldn't change it necessarily, but you got to ask the question when you look at that data. Here are some other factors to consider. Some will surprise you, some won't. Working too many hours, 3% increased risk of burnout for each additional hour worked above the average for your specialty. Taking night or weekend call, 3 to 9% per weekend. I'm not quite sure how they get that number, but if you take a lot of call, that's a lot of burnout. Taking work home, 2% per hour that you work at home. Work-home conflict, not surprisingly, substantially increases the risk of burnout because of that innate stress between what's going on at home, what's going on at work. Working in a private practice, surprisingly, you'd think you'd be less stressed because you have more latitude in how to manage your day and manage your practice. But in fact, the surveys show it's a greater risk of burnout no matter what the specialty. Mid-career physicians like me between ages 40 and 55, that's almost not me anymore, 25% more likely versus those under 40 or over 55. And then finally, people who do computerized order entry, 29% more likely to experience burnout. So, these are things that a lot of these things are sort of intrinsic to the way we work, so we have to look at what we do and reconsider whether we should do them the way they do. This was a study out of JAMA, looking at a meta-analysis, looking at comparing physician-directed interventions and organizationally directed interventions. And the physician-directed interventions are important. That's things like self-care, stress management, mindfulness, small effect because it's seen on an individual person-by-person basis. But organization-directed approaches really did have a much greater impact overall, and that really means enhancing the physician support systems and managing schedules and workloads. So finally, one quick note, my own personal experience, I paid for my clinical nurse to go back and become a nurse practitioner so that she could start seeing patients on her own. It really did offload some of the patients I would have to see. We tried to move people to just see patients 2 days a week in the office instead of 3, so I was able to drop one office, have 2 days a week in the office, and now my 5th day is sort of a free day. I can make up time in the OR if I need to, I can make up office time, or it can be an academic or administrative day, which really does make it less stressful when I can do my work on that Friday in the office and not have to take it home with me on the weekend. So what is the way forward? I would just put these issues out there. Be aware of those risk factors for burnout. And there are a number of them, and many of them are intrinsic to the way that we work. Recognize signs of cognitive scarcity, which means depleting your mental bandwidth to the point where you start tunneling in. Exercise more or be healthy, because self-care really is not selfish. And then consider within your organization, to the extent that you may have any leadership roles, consider structural changes, increasing the involvement of mid-level providers, let them do some of the screening to see the patients, and then you see them, reduce the incentives for people to overwork and do too much, and sometimes see if there's ways that you can reward your physicians or members of your organization for other activities besides just seeing more patients and doing more surgery. Anyway, that's a lot. Thank you very much. Happy to take questions.